Hello. Hi. Good evening, everybody. Uh, the time is up for today's volume, which is the last volume of this series of On Era. Uh, I would request you to allow me to take few more minutes. Let's wait for another couple of minutes and for other, doctors to join us so that everybody is benefited. Just another 2, 3 minutes more. Thank you. Thank you for your understanding. Very good evening, doctors. Those who have joined us a few moments back, uh, I would request that let's wait for another minute or so, and so that other doctors can also join us who have been invited to this series. Just another 1 or 2 minutes, not more than that. Thank you for your patience. Thank you. Very good evening, distinguished guests and valued participants. Welcome to this volume 3 of ERA webinar. This happens to be the concluding volume of this series on ERA. Today's protocol would be proper protocol compliance to optimize your clinic's error outcome. This is very important when we talk about, I'm sure last two sessions, volumes were also enlightening. Those of you who were there through the series, volume 1, volume 2, and this is this is equally important when we talk about optimizing the error outcomes, right? Uh, uh, by now, those who were there with us in earlier volumes, they know the speaker. Hi, Dr. Tiffany. Thanks for joining us today. Tiffany will be talking on the protocol compliance, and you all by this time know who Tiffany is, but I would like to still take a very quick minute and introduce Tiffany for the interest of those who have not been with us in the earlier two volumes. So Tiffany has earned her bachelor's degree in animal biosciences from the Pennsylvania State University and PhD in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling both embryonic aneuploidy and endometrial receptivity using genetic testing. Tiffany has over 15 years of clinical laboratory experience as a fully trained embryologist and is certified by the American Board of Bioanalysts as a technical supervisor in both embryology and andrology. In addition to clinical laboratory experience, she coordinated many aneuploid and single gene cases as PGT director at a large IVF clinic in Philadelphia, Philadelphia. Tiffany made the move to reproductive genetics in 2016 when she became the PGTA lab manager at iGenomics New York. In 2017, her primary focus in the company shifted to endometrial testing when she took on the role of endometrial specialist, concentrating on ERA, EMMA, and ALICE tests. Today, she serves as the Global Endometrial Product Director for iGenomics. Furthermore, Tiffany has published and presented research papers at conferences such as Pre-Implantation Genetic Diagnosis International Society, that is PGDIS, the American Society of Reproductive Medicine, the European Society for Human Reproduction and Embryology, and the Pacific Coast Reproductive Society too. She's an instructor at Eastern Virginia Medical School and is a member of the American Association of Bioanalysts, the College of Reproductive Biologists, and the American Society of Reproductive Medicine. So this is a bit about Tiffany, and thank you once again, Tiffany, for taking your time and joining us today. I know it's too early in the morning in your part of the world, so I hand over the session to you. The floor is all yours. Thank you. And before just one point I would like to add for the benefit of doctors. You can see on the top of the left-hand side, top of your screen, there is one, option given that is Q&A. If once you have questions, you can simply post your question in Q&A box. And once Stephanie is over with her today's presentation, I'll be reading out the questions and for her replies. Thank you very much. Over to you, Tiffany.
Thank you, Vikram, for the introduction. And thank you again for having me here today. As Vikram introduced, today is the final series in our volume. Today, we'll be talking about patient-related factors and their effects on ERA reproducibility, of course, with the overall objective to have proper protocol compliance to optimize your clinic's ERA outcomes. So similar to the previous volumes, if you attended, I'm going to do a quick introduction of implantation and the ERA test itself. So implantation is a significant rate-limiting step in both human reproduction and IVF, and we know that it largely hinges on two essential players, which is the embryo and the endometrium. Again, for years, we've focused on optimizing the embryo. This is through fertilization techniques, such as the introduction of intracytoplasmic sperm injection, culture media advancements, introducing new incubator systems, going from, for example, 20% oxygen to low O2, how we freeze embryos, going from slow method to vitrification, which results in much higher survival rates. And more recently, the introduction of PGT specifically for aneuploidy screening. But even if we look at these high-tech advancements such as PGT, we still see that implantation failure occurs in about 1/3 of these cases. So what we must do is look at the other player, which is the endometrium. Now, the ERA test, or endometrial receptivity analysis, is a molecular assay used to determine each woman's unique personalized embryo transfer timing, therefore allowing us to synchronize the embryo transfer with the individualized window of implantation. For ERA, we use next-generation sequencing to measure the expression of 248 genes involved in endometrial receptivity. After sequencing, an in-house designed computational predictor analyzes the data obtained and classifies the endometrium as either being receptive or non-receptive. We then pair this result to recommendation for a personalized embryo transfer, or what we call a PET, according to each patient's specific endometrial profile. Now, there has been an abundance of research performed on ERA specifically, both internally and externally. So the research by iGenomics has demonstrated that synchronization between an implantation-ready embryo and a receptive endometrium increases the chances of success in assisted reproductive treatment. Now, even more so than internal publications, we have an even more external publications available that are performed by independent groups and clinics. And these groups have also published similar results from their own patients after guided embryo transfer according to the ERA results. Now, taking time to focus on the specific indication, so recurrent implantation failure, or RIF, is the primary indication for ERA. We see that we have a high number of publications specific in this group. In fact, ERA itself has the highest published clinical rates for patients with RIF compared to any other endometrial receptivity test in the market. RIF patients who undergo a PET guided by ERA have significantly increased clinical outcomes versus those RIF patients who did not undergo a PET by ERA and instead underwent standard embryo transfer timing. Furthermore, RIF patients who undergo PET guided by ERA are found to have similar outcomes to those achieved by good prognosis patients without a history of implantation failure. And in a recent systematic review and meta-analysis that assessed 36 different therapies for RIF, this analysis included over 29,906 patients with RIF, showed that ERA is among the top therapy and intervention to improve implantation rate and live birth rates in this particular population. So, as it's been demonstrated, that synchronization between an implantation-ready embryo and a receptive endometrium with ERA increases the chance of success in ART, how can we replicate these same results and findings to optimize our ERA clinical outcomes for our own patients? And the answer here is ERA protocol compliance. So why is protocol compliance so important when it comes to ERA? And the answer is reproducibility. We want to make sure that the results we obtain in the ERA mock cycle are the same in the transfer cycle. So for example, when we perform the biopsy at 120 hours in the HRT cycle and we obtain a receptive result, we want to ensure that when we're transferring in the PET cycle, that the patient, again, is going to be receptive at 120 hours. So what about reproducibility from month to month from patients? Do we see a change in the transcriptomic profile from one cycle to the next? Well, we've actually performed this study, and what we found that the results are reproducible up to 40 months. Now, this isn't saying that after 40 months, the results are not reproducible. This is just how far that the study went to. And what we saw was total concordance between patients. Transcriptomic variation between cycles, even 3 years later, is quite rare. Now, with that said, we have to ensure that we're replicating the same cycle protocol and there's no changes to patients, say BMI or uterine alterations. And we'll go into more detail here. But if you do want to hear more about this particular paper, you can refer back to volume 1, where we do a deep dive further. Now, the reproducibility has been challenged in the field. Again, we have another example showing that the results are reproducible from month to month under those certain stipulations, i.e. replicating the same cycle protocol. Again, we go further detail into these particular papers in volume 1 from our April 6th webinar that you can find online. But what can affect the reproducibility of ERA? I mentioned a few examples such as cycle protocol or patient BMI, but one example is overall adherence to the recommended PET timing. If we're saying to transfer at 120 hours, are you indeed transferring at 120 hours, or is there a deviation from this recommendation? Replicating the cycle type, so HRT versus natural, you need to use the same cycle type in both the ERA mock cycle and the PET cycle for a patient. But not only do you need to replicate the cycle type, but also replicate all cycle medications. This includes progesterone administration type, dosage, etc., in both the mock and PET cycles. Considering the use of additional medications, so gonadotropins and steroids, and their effects on reproducibility, taking into consideration major shifts in patient BMI between mock and PET cycles, alteration to the uterine cavity, for example, surgeries, endometrial thickness and pattern, and elevated endogenous progesterone levels. So how do we ensure ERA reproducibility? Again, proper protocol compliance. So we know that not in all cases, the protocol is not followed. We see this through our own experience with our RCT published back in 2020, where we had a 50% dropout rate, mostly due to no protocol compliance. This could have been transferring at the incorrect time, changing protocols, or any of the factors I had previously mentioned. Again, if you want to hear more about this, you can refer back to volume 1, where we do a deep dive into this particular RCT. I also shared an example of a more recent publication where the results were not as favorable for ERA versus standard FET or fresh ET. However, when we did a reanalysis of this data from our own RCT from the same participating clinic, we actually found significantly improved outcomes with ERA and PET because we could properly control that the cycles were performed correctly without protocol deviation. So since RCTs require extreme scrutinization to only include clean data, if a greater than 50% dropout rate was observed in patients participating in the RCT, what do you think the dropout rate would be in clinical cases where this data is not constantly being scrutinized? So again, the factors that can affect reproducibility ERA. In our first volume, we went through elevated endogenous progesterone levels. So this is extremely important. We need to ensure that the patient is not previously exposed to any progesterone prior to starting her first intake of progesterone. And again, refer back to volume 1 to hear about that particular factor. And then in volume 2, we talked about replicating the cycle type, replicating all cycle medications, and considering the use of additional medications in the ERA cycles. So that leaves overall adherence to recommended PET timing, major shifts in patient BMI between MOC and PET cycles, alterations to uterine cavity, and endometrial thickness and pattern. So those will be the 4 factors which I felt that they were very much so related to the patient that we'll discuss in this final chapter. So let's skip and we'll start with major shifts in patient BMI between the MOC and PET cycles. So what does the iGenomics protocol pertaining to ERA and patient BMI say? Well, the indication again is patients with reoccurred implantation failure, since they are at higher risk of having a displaced window of implantation. With that said, though, there are studies that have shown that there are other circumstances in which patients are at higher risk for having a displaced window of implantation. And one of these are patients with a BMI of greater than 30. So what was found in this paper? So this was a paper published several years ago by Stanford Group in the United States, in which they found obesity, as defined as a BMI greater than 30, is associated with a significant increase in non-receptivity rates. In fact, if we look at the chart below, we go from normal weight, overweight, obesity, again defined as greater than 30 BMI, and then morbidly obese. And we can see that the receptivity rates, as indicated by the blue bars, decrease as BMI increases. Now, the same relationship exists with non-receptivity, except we see lower non-receptivity rates in the normal weight group, slight increase in overweight, and then by the time we get to obesity group and morbidly obese group, we see significant increase in non-receptivity rates. So this altered endometrial gene expression in obese patients may contribute to lower implantation rates and increased miscarriage rates seen in obese infertile patients. But how can a change in BMI affect the reproducibility of the ERA? Again, I refer back to the endometrial manual, where we discuss the reproducibility of results. Again, the ERA results have been proven to be reproducible for at least 36 months, always that the following are accomplished. Again, endometrial preparation protocol, endometrial thickness, which we'll talk about soon, intervention at the uterine level, which again we'll talk about, and then endogenous progesterone levels, a big one that we started off the series with volume 1. But we need to keep into account changes in BMI might be accompanied by a shift in the window of implantation. So the ERA test might need to be repeated after significant BMI changes. For example, changing from a BMI of greater than 30 to less than 30, or vice versa, to ensure accuracy of the results. Now, why would BMI affect reproducibility? Well, this is clear. The endometrium is a hormonally regulated tissue. Changes in BMI can change how hormones are metabolized and therefore affect the window of implantation. So again, if there has been a major shift in your patient's BMI between the ERA MOC cycle and subsequent PET cycles, it is recommended to repeat the ERA test to account for any shift. So giving an example, say the patient's BMI at the ERA MOC cycle is 25. She undergoes her first PET at a BMI of 25. We expect reproducibility between these results, permitting that everything has been replicated as far as cycle protocol and proper timing has been accounted for. Now, let's say that the patient has delivered a baby from that first PET cycle and comes back a year and a half later for another PET cycle. However, her BMI is now greater than 30. The results may not be reproducible from the initial ERA cycle, even though it's less than 36 months in between the initial biopsy and the second PET. In this case, it would be wise to perform a new biopsy to account for any changes that this increased BMI has an effect on the window of implantation. What about alterations to the uterine cavity? As the example I gave with surgeries. So what does the manual say about how uterine interventions affect reproducibility of ERA? Well, interventions at the uterine level may affect the window of implantation. After this type of intervention, it should be evaluated if a new ERA needs to be performed. Indeed, if your patient requires any intervention at the uterine level prior to embryo transfer, the ERA test should be done after this procedure also. So example, if your patient is having a removal of endometrial polyps prior to transfer, then the ERA test should also be performed following the removal of the endometrial polyps to omit a potential source of artifactual results. So we certainly wouldn't want to perform the ERA test first, then remove the polyps, and then transfer. The proper sequence would be uterine intervention to remove the endometrial polyps, then ERA, and then transfer. So we want the endometrium in the same conditions between the transfer and the previous mock cycle. Then we move on to endometrial thickness and pattern. We touched upon this slightly in our Volume 2 series, but here I'm going into a little bit more detail about how this can affect the reproducibility of ERA. So again, referring back to the endometrial manual, what is the iGenomics protocol pertaining to ERA and endometrial thickness? So again, we discussed that the indication for ERA is patients with RAF. However, there are other indications such as high BMI of greater than 30. And then if we look at the second one, patients with endometrial atrophy. So endometrial thickness less than 6 millimeters. Now, last year at ESHRE, our group shared our results looking at endometrial receptivity according to endometrial thickness. We had 3 ranges, the first being less than 6 millimeters, defined as an atrophic endometrium. The next defined between 6 and 12 millimeters, which we refer to as a normal endometrium. And then the final group was greater than 12 millimeters, which we refer to as hypertrophic endometrium. And what we found was that a thin endometrium of less than 6 millimeters is associated with a significantly higher rate of displaced window of implantation compared to the normal lining or hypertrophic endometrium. So, in order to ensure reproducibility results, endometrial thickness must be within the same range from one of the following 3. So again, less than 6, 6 to 12, or greater than 12 in both the biopsy and transfer cycles. So in this scenario, if the patient's endometrial thickness falls within 2 different ranges between the ERA mock cycle and transfer cycle, then the cycle should be canceled, and as this could affect the window of implantation and reproducibility results. So we'll give an example here. Say you have a patient who has usually a normal lining between 6 to 12 millimeters. She undergoes her ERA mock cycle, but her endometrial lining only gets up to about 5.5 millimeters. As this is not usual for the patient, we would recommend canceling that ERA mock cycle and then starting a new cycle in where you achieve her usual lining of 6 to 12 millimeters. Alternatively, if you had a patient who during her ERA mock cycle achieved a lining between 6 to 12 millimeters, which is usual for this patient, but then for some reason during the transfer cycle, her lining is greater than 12 millimeters, we would recommend canceling the transfer cycle and achieve normal lining between 6 and 12 for that patient. Now, this is not to say that you cannot perform the biopsy in a lining less than 6 millimeters. If this is the patient's normal endometrial morphology, where she is consistently having a thin endometrium, then you can certainly proceed with the ERA mock cycle. Now, albeit she may have a greater risk of a displaced window of implantation, this does not mean that she cannot achieve receptivity or the results won't be reproducible. We just want to make sure that her endometrium is always in one of the 3 groups for both the ERA mock cycle and transfer cycle. Now, if you do know, on the iGenomics test requisition form, we do have an indication for endometrial thickness in millimeters and the date of the thickness measurement. In an HRT cycle, we recommend taking this measurement before the first intake of endogenous progesterone. This helps us know if the results are reproducible, especially if we receive more than one endometrial biopsy. So in an example, if we have a first ERA biopsy in which the lining is 8 millimeters, and then a second ERA biopsy for the same patient in which the lining is 5.5 millimeters, then those results will not be able to be correlated because the change in endometrial thickness range could affect reproducibility. And then the final factor that I'm going to discuss today is overall adherence to the recommended PET timing. So let's look at this example here. In the ERA mock cycle, say we're performing an HRT, we perform the endometrial biopsy at 120 hours of progesterone. What the result finds is that the patient is pre-receptive 1 day at this time. So then we give a PET recommendation to perform transfer 24 hours later at 144 hours, as this is when the patient will achieve optimal receptivity. Now the patient's going to undergo her PET cycle the next month. And we know that from the previous ERA mock cycle, she is receptive at 144 hours. But for whatever reason, instead of performing transfer at 144 hours, she actually gets another additional day of progesterone and transfers occurs at 168 hours. Well, the embryo is transferred now to a window that is already closed, so there's no chance of implantation. And although this might be intuitive that we should follow the PET recommendation, we know that this does not always occur. In fact, I've done audits at clinics where I've seen this exact scenario where we say, okay, transfer at 144 hours, and for whatever reason, the patient transferred 168 hours. Now, we know that, again, timing and reproducibility is extremely important. Here, I can actually give a case study. This was, again, discussed in volume 1 in more detail, but essentially, the clinic decided to perform an additional 3 biopsies, actually, or 2 biopsies, instead of following our recommendation for biopsy timing. Not only were we able to show reproducibility, but we were to show that when we don't follow the recommendation, the patient's going to be in a different phase of receptivity. So for example, here we saw that the patient's biopsy was taken at around 106 hours, and she was pre-receptive 2 days. We recommended a second biopsy be performed 48 hours later at 154. Instead of doing this, the physician gave the patient 194 more hours of progesterone. So this was an additional 40 hours of progesterone than what our recommendation indicated. This had then taken her, actually, if I can have a pointer. Here we go. The second biopsy at 194 hours took her to a late post-receptive phase. We then recommended to perform a third biopsy 24 hours sooner at 170. We recommended again 154 based upon the first result, but instead of this, the clinic decided 170 hours of progesterone, still an additional 16 hours more than the recommendation. Finally, in the fourth ERA mock cycle, the physician took the biopsy at 148 hours, so within that 154-hour range, and finally achieved receptivity. So this is just a real-life example of what can happen when we don't follow the recommendation for the ERA. Again, the first biopsy at 106, we recommended 154 as our optimal receptivity. And instead of giving 154 hours of progesterone, this physician gave 194 hours of progesterone, taking the patient well into the post-receptive phase. Now, fortunately, this was with biopsies and not an embryo transfer, so we did not waste any good embryos on in a post-receptive phase in which the window of implantation was already closed. But again, I think this illustrates that errors can happen, and when we don't follow the PET recommended timing, we could take the patient outside of optimal receptivity. So why do we see deviations to the recommended PET timing? Well, this could be due to incorrect calculation of PET timing for that cycle. When we're dealing with a number of hours, this can get a bit confusing. So sometimes this can lead to error in calculating the number of hours a transfer should occur. Maybe patient error. We've seen this quite commonly. So especially for patients without a lot of experience with undergoing IVF, this is quite overwhelming process for them, understanding what medication to take when in their cycle. For example, I had a patient confuse her estradiol and progesterone and swap them. So in the end, we had to cancel that cycle. So that's always a possibility. And a scheduling error. We're used to transferring after 5 full days of progesterone, for example, in an HRT cycle. And sometimes we just go on autopilot and we'll set the patient up for a transfer after 5 days of progesterone instead of when her optimal receptivity window of implantation is. So iGenomX has created tools to prevent deviations to the recommended PET timing. And the best example of this is our Personalized Embryo Transfer Calculator, or PET calculator. So let's go through an example here of how the PET calculator works. First, you're going to indicate cycle type. Did the patient undergo an HRT cycle or a natural cycle? In this example, I chose HRT cycle. Then we're going to select what type of embryo the patient is transferring. Is she transferring a blastocyst, or is she transferring a day 3 cleavage stage embryo? You'll also note that there's a box for a biopsy cycle, so you can use this in order to time the cycle biopsy or the PET transfer. So in our example, I'm going to choose a blastocyst transfer. Then we ask to indicate the number of hours after starting progesterone or the day of the cycle, so P+1, maybe P+5, P+6, in which the ERA report recommends the transfer of the blastocyst. So I chose hours on the ERA report, and I typed in 120 hours in this case, since that is when my patient was found to be receptive. In the fourth box, you'll select if you want to go off by day of progesterone intake or transfer date. Now, I recommend to clinics to choose your desired transfer date because usually you have more tight schedule with transfer versus when the patient can start progesterone. For example, maybe you try to avoid transfers on the weekend. So in this case, I chose a transfer date of a Thursday, which I think in this case was Thursday the 27th. I also chose the hour of my desired transfer, which was 9 a.m. You'll then be prompted to calculate, and then you'll receive when the first progesterone intake date and time should be for this case. So in this case, sorry, it's a bit small for me, it indicates that the patient should start on June 22nd at 9 o'clock a.m. in the morning. This way, she's able to achieve 120 hours at her blastocyst transfer on June 27th at 9 a.m. So again, this calculator can be used to not only calculate the PET timing, but also your biopsy timing. So for example, if you have the patient underwent a biopsy and she was post-receptive and recommended to rebiopsy 24 hours sooner, you would just pick your biopsy cycle here and then enter all the information on the report and your desired date and time of biopsy. So this is a very handy tool. This has been around for quite a while now, but there are a lot of physicians who aren't aware of this. So I like to introduce this because it is really helpful to use in the clinic. Now, furthermore, just last month, we introduced a new clinic ERA tool. And this is essentially a checklist to ensure reproducibility between the ERA mock cycle and the transfer cycle. So in the left column, which it may be difficult for you to see, we have the factors that can affect the reproducibility of the ERA results, which we've gone through in the last 3 volumes of this webinar series. The second column is going to be where you enter all this data for the ERA mock cycle. And then the third column is where you're going to enter all this data for the PET cycle. This way you can ensure proper reproducibility between both of the embryo transfer cycles. Not only is this a great tool for clinics to use, but also for patients. This particular checklist can be downloaded on our website, which I'll share next, and shared with the patients to ensure that she understands exactly when she needs to take her progesterone, for example, what the administration type should be, what the dosage should be, so we can ensure proper reproducibility between the ERA mock cycle and the transfer cycle, again, optimizing her chances of implantation upon transfer. Now, last month we did introduce a new ERA hub online, and the objective of this ERA hub is to ensure proper protocol compliance for superior clinical outcomes. This ERA hub can be found at the website here. It should also be available if you go to igenomics.com. You'll see it in our igenomics in your local region. There should be a banner in which you can click on it, and it'll take you right to the new ERA hub, which is a worldwide resource. Now, here on this hub, you'll find, again, the personalized embryo transfer calculator that we went through, and the new ERA clinical tool checklist, which again can be downloaded and shared with patients. In addition to these clinical tools, we also have expert experience from around the world. We have tips from our global scientific advisors, a webinar series, including this webinar series. You can access all the volumes here, along with other webinars that we've performed or interviews in the past. For example, we have a Meet the Expert panel from last year's ASRM, and we'll be adding our new Academy sessions from ESHRA in just a few weeks. We also will be introducing a new ERA protocol video, which is a short blip that goes through the endometrial manual in about 2 minutes versus maybe having to read all through it, and gives you the important points to ensure proper protocol compliance in ERA and reproducibility. We have updates to what's going on with ERA, including our ERA publication list that will take you to the links of all the ERA publications. And then finally, this is a new tool that we're offering globally. It's endometrio pre and post test webinars. These are live in which your patients can register, and our nurse scientific advisor in the US conducts these every few weeks. We will have recordings available too for your patients to access. But again, patients from around the world can sign up and register for these pre and post test webinars, where not only will undergo information about the ERA test, but also Emma and Alice. So I encourage your patients to also check out this site for more resources they may have questions to. So what are the conclusions from this volume? 1, patients with a BMI greater than 30 have been shown to have a higher risk of having a displaced window of implantation, in which ERA can be applied to help identify the optimal moment for embryo transfer. Furthermore, changes in patient BMI might be accompanied by a shift in the window of implantation. So in cases of significant shifts in BMI, the ERA test may need to be repeated. Intervention at the uterine level may affect the window of implantation. it should be evaluated if a new ERA should be performed following a uterine intervention. If a patient requires any intervention at the uterine level prior to embryo transfer, the ERA test should be performed after this procedure. Atrophic endometrium, defined as less than 6 millimeters, is associated with a significantly higher rate of a displaced window of implantation versus normal lining between 6 to 12 millimeters or hypertrophic endometrium, defined as greater than 12 millimeters. Therefore, ERA can be applied to these patients to help identify the optimal moment for embryo transfer. Moreover, endometrial thickness must be within the same range, either less than 6 millimeters or 6 to 12 millimeters or greater than 12 millimeters in both the biopsy and transfer cycles. Although intuitive, overall adherence to the recommended PET timing is imperative to ensure transfer into an endometrium that is at optimal receptivity. However, deviations to this have occurred due to miscalculation of hours, patient error, and/or scheduling errors. To prevent protocol deviations, including PET timing and other deviations affecting reproducibility, tools such as the PET calculator and clinic patient ERA tool can be utilized. These tools, along with expert experiences, tips from our global scientific advisors, publication, and live patient webinars can be assessed through our new ERA hub. So that brings me to the end of my presentation. I think we can open up now for Q&A. So Vikram, I'll invite you back in case you've received any questions.
Thanks, Stephanie. Unfortunately, I don't have any. Very few questions are there, I think. Yeah, let me read out those questions to you. Yeah. While assessing the receptivity by ERA, what is important? A, only the progesterone route dose to biopsy time, or B, also the estrogen priming, like changing the estrogen dosing would impact the receptivity. Is it like that?
Yes, that's a really good question. We receive this, we do receive this question quite a lot. So the most important thing when it comes to cycle protocol replication, ER reproducibility, does pertain to the progesterone protocol itself. So we always want to ensure that we're using the same progesterone administration type, the same dosage. Everything pertaining to the progesterone should be identical between the mock cycle and the transfer cycle, with the exception of exposure time if indicated that the patient does have a displacement. Now, ideally, we do want to replicate the entire cycle protocol, including estradiol priming, though this is not as important as the progesterone protocol. So, for example, if we see that in the mock cycle, maybe your patient achieved a lining of 6 to 12 millimeters, but now in the transfer cycle, her lining is not building up as much as it did. You can certainly increase the estradiol by maybe giving additional days or increase the dosage in order to achieve the similar endometrial thickness between the two cycles. So ideally, we want to keep everything the same, but we have a little bit more leeway when it comes to estradiol priming because we can, this won't affect the reproducibility like progesterone can.
I hope the doctor has got the answer. And another question is, Tiffany, if for a patient the endogenous P4 is always greater than 1 nanogram in multiple cycles, how can we plan the HRT biopsy cycle for this patient?
Yeah, this is really difficult because we have seen this before where patients have just elevated endogenous progesterone levels. through the proliferative stage and the secretory phase. So sometimes we see that might be due to some sort of mutation, but it's something that we can see in a patient. The good news is that it's not common, but for those patients in which it does happen, we can't guarantee the reproducibility of the ERA results. We recommend maybe trying a different cycle type, maybe in a natural cycle. There's some physicians here who will try different protocols in order to decrease the patient's own endogenous progesterone, but we haven't validated those particular protocols and their effects on reproducibility. So unfortunately for these cases, we can never fully ensure reproducibility when we have elevated endogenous progesterone levels throughout the entire cycle.
Thanks, there. Tiffany, one of the participants has requested if you can just play the concluding slide again, just if you can keep it on the screen. Yeah, thank you. So, thanks a lot. We have one more question here. Is any route of progesterone recommended in ERA? And is it important to replicate the route in the actual cycle also?
Yeah, so you can choose any route of progesterone you'd like, whether it's IM, vaginal, or a combination, but it must be replicated between the ERA mock cycle and transfer cycle. So not only does the route need to be replicated, but also the dosage itself. So if you use 400 milligrams of vaginal progesterone twice a day in the mock cycle, you want to use 400 milligrams of vaginal progesterone twice a day in the transfer cycle. So everything should be replicated in sense of administration type and dosage of progesterone.
Thanks again. There is a question from one of the doctors, and it says like he's getting quite a few invalid results. What could be the probable reason?
So it depends. We have several types of non-valid results. One of the more common ones I would say is probably invalid RNA. And with invalid RNA, what happens here is that the RNA degrades and then we're not able to obtain a proper endometrial transcriptomic profile. And the major cause for an invalid RNA result is usually sample size. So if the sample size is too large, there will not be enough RNA stabilizing buffer in the ERA cryotube to preserve the RNA. The RNA will degrade, and then we get one of these invalid profiles. So the sample size should not exceed 70 milligrams, which is about the length from, you'll see on the ERA cryotube, we have a white line towards the bottom. This equates to about 7 millimeters of tissue. Another cause could be a high presence of blood or mucus, which impedes the ERA stabilizing buffer to penetrate the tissue and preserve the RNA. Not properly handling the sample at the clinic. So what I mean by that is as soon as you take the endometrial tissue biopsy, you want to introduce it into the ERA cryotube, shake it vigorously for a few seconds, and then immediately place in the refrigerator at about 4 to 8 degrees Celsius for a minimum of 4 hours. So this immediate refrigeration is required in order to help preserve the RNA. Other issues we could see is that if the sample is exposed to extreme heat, this can degrade the RNA. So if it's very hot out, we recommend sending the sample in with an ice pack. And we just want to prevent samples that are in transit too long. So for example, in the United States, we only tell our clinics to send the samples Monday through Thursday only, because if they send it out Friday, we won't receive that sample until past the weekend because of when delivery occurs. So invalid RNA is because of RNA degradation. We have to keep in mind that RNA is much more sensitive than DNA. So RNA can degrade quite easily and rapidly. So we have to do our best to preserve it. The other type of non-valid is insufficient RNA. And that's simply when we don't have enough RNA present. And that's mostly because the sample size is too small. So again, we want to ensure that we're taking an adequate sample size. And then lastly is non-informative, which is quite uncommon. It's less than 1% of biopsy cases we receive. And usually this is innate to something within the ERA cycle itself. So we know, for example, one risk factor for a non-informative profile is an elongated estradiol priming, so greater than 17 days of estradiol before introducing progesterone. Now, this has been related to endometrial bleeding, and for example, endometrial bleeding is one factor that can lead to this non-informative profile, which is essentially a transcriptomic profile that does not match any within our controls. So there's very easy ways to avoid these non-valid results. Again, taking the proper sample size, following the protocol for handling and processing at the clinic, and just ensuring that the patient's not on too many days of estradiol before starting her progesterone are just a few ways to avoid these.
Thank you, Tiffany. Another couple of questions we have. Can we use ERA for cleavage stage transfer?
Yes. So you can use ERA for cleavage stage transfers. Now, it's very important when you take the biopsy, you still want to take the biopsy at the timing of blastocyst transfer or implantation, because this is when we expect the endometrium to be receptive. So for example, even if you're planning on transferring a day 3 cleavage stage embryo, we wouldn't want to take the biopsy after only 3 days of progesterone. So this would equate to about 72 hours of progesterone exposure, because I can guarantee we almost will always get a pre-receptive result. In this case, you still want to take the biopsy at 120 hours in an HRT cycle. And then how you account for a cleavage stage transfer is that you'll just subtract 48 hours from the recommended PET timing of the blastocyst. So for example, if you take the biopsy at 120 hours of progesterone, and the patient comes back pre-receptive one day with recommendation to transfer 24 hours later at 144 hours, so 120 plus 24, 144 hours, but that's for a blastocyst transfer. In order to account for day 3 cleavage embryo transfer, we would just simply take 48 hours from 144, and we would transfer that cleavage stage embryo at 96 hours of progesterone. You'll see too on the report, there is it explains this underneath the results, how to account for a cleavage stage embryo transfer. And then I will go back really quick in the PET calculator, because we also do account for that here. In the second box, you can see here, select one of the following options. The second one is day 3 embryo transfer. So you can even use the PET calculator to account for a cleavage stage embryo. The important thing here is that we're still performing the biopsy at 120 hours, which is normally when we would transfer a blastocyst, since that's the stage of embryo that actually implants. We account for the day 3 cleavage after we get the PET recommendation.
Thanks, Tiffany, again. Does use of betadine to clean the vagina affect the results?
Yeah, that's actually a really good point, Vikram. And I didn't mention that with the invalid RNA. The use of betadine can potentially lead to an invalid RNA if this tissue is contaminated. So as I said, RNA is quite unstable. So we need to prevent any contamination just to prevent a non-valid or invalid RNA result. So instead of using betadine, what our recommendation is just to clean the vagina and cervix with sterile gauze. If you do want to use some sort of fluid during the initial wash before the biopsy, then you can use just sterile saline to do a quick wash with your sterile gauze. But we should prevent, in order to prevent contamination, we don't recommend the use of betadine.
Thank you, Tiffany. And in the interest of the participants, I would like to, sort of, inform them that the PET calculator, you will find the link to PET calculator with the report, right, that you receive. It's in the body of the mail along with the attachment of the report. It's in the body of the mail. You will see a link in blue color. You have to click on that. That link goes to PET calculator, which was properly explained by Tiffany. I think we don't have any more questions, Tiffany, but thank you very much for your enlightening talk. And thanks to the attentive audience too. And let's carry forward this sharing of knowledge that we did here today and in last 3 volumes, including today's. Thank you very much, Tiffany. And thank you
so
all
much
for joining us.
Have a good day. Thank you.
Bye-bye.